Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Pleasure to have you join us for our podcast today. And today we're really happy and excited to have one of our associate editors in the International Journal, Dr. Junzo Chino, who is the Director of Brachytherapy in the Department of Radiation Oncology at Duke University Medical Center in Durham, North Carolina. And today we're going to talk about a really great article that was published recently titled Recent Advances in Gynecologic Radiation Oncology. This was published in the journal Cancer. Junso, thank you so much for joining us and for accepting our invitation to talk about this really important topic.
Thanks so much, Pedro. It's definitely my pleasure.
Excellent. So I know we have a lot of questions, so I'll get on to the first question. And I wanted to just start by asking, how has the integration of molecular classification systems changed the role of radiotherapy in endometrial cancer management today?
This is a really great question and gets to really a fundamental issue about how best we should integrate radiation therapy, particularly for the stage 3 or node positive cancers. It's a very controversial subject. It's clear that the analyses from PORTEC 3 and GOG 258 that molecular classifications not only affect the prognosis of our patients, but also provide insight into a differential response to adjuvant therapies. For instance, mutated patients probably don't need combination therapy, and in both studies they did really well, but they each got something, either chemo or radiation. And actually, they may not need any adjuvant therapy at all and are really candidates for potential dose de-escalation. For patients with dMMR, they also clearly benefit from immunotherapy. From B21, we know that for this node positive patients postoperatively. Though what, if anything, should be combined with this is more controversial. In B21, everyone got radiation therapy, but from the sub-analysis of 258, radiation therapy really didn't improve over chemotherapy, or at least combined chemotherapy alone. And so it's a little bit more controversial, but one thing that's absolutely clear is that immunotherapy is indicated for these patients. It gets more complicated when we get to the non-specific mutational profiles in P53. In the 258, those with P53 wild type or NSMPs seem to drive most from pelvic control in regards to overall disease-free survival, at least more than the other cohorts. And so they might be better indicated for radiation therapy. Alternatively, those with P53 mutations, the risk of systemic therapy really is so high, it far outweighs the potential benefit or lack thereof of pelvic control. Due to this data, at Duke, we've been putting together a novel classification-based treatment algorithm which recommends pelvic radiotherapy for those that are P53 wild type, while prioritizing systemic therapy for P53 mutants, maybe integrating vaginal brachytherapy as needed. For dMMR patients, we're also prioritizing immunotherapy with systemic therapy, and again, only really using vaginal brachytherapy for a lot of those patients if indicated. We really don't know how this translates yet over in early stage cancers and haven't really changed our recommendations for vaginal brachytherapy, which we do for most of these high immediate risk factors. But there is a new trial, PORTEC 4A, which has been recently reported as a positive trial looking at tailored targeted therapy based on profiles. And I'm just really waiting for the manuscript for more details on exactly how this might affect each specific clinical scenario.
Yeah, that sounds great. And thank you for that very um, uh, laid out and articulated introduction on this principle, and would love to see that Duke algorithm as well. So now, Jin, so let's talk a little bit of, and you mentioned brachytherapy. In what ways have there been technological advances, and particularly again, as you look at MRI guided brachytherapy, how have these influenced local control and toxicity outcomes in patients with a different type of cancer, in cervical cancer?
This is one of the most exciting developments for cervical cancer for radiation therapy in the last 20 years. When we look at historical point A based plans, they're actually fairly effective at controlling cancers. In RTOG 9001, there's about an 85% control rate, again, if it's done well. But there's significant toxicities due to the fact that we just don't see tumor volumes or organs at risk on these types of plans. What MR-guided treatments have allowed us to do is more accurately target the tumor and identify normal structures in such a ways that we can take opportunities to spare them. One of the emergent properties of all this, though, is with better tumor delineation for the more locally advanced patients, we've been using more and more interstitial needles. In Embrace One, which is a retrospective, or actually prospective registry-based trial looking at MR-guided brachy, interstitial needles were added in about 40% of patients. And then in the next iteration of that trial, Embrace 2, it went all the way up to 74%. The results of this Embrace study have shown that image-guided brachytherapy have control rates actually greater than 90% for even really locally advanced patients like the 3Bs and 4As, whereas toxicity rates have halved from historical controls down to about 7, 8%. This is a real gain for our patients, and personally, I've seen a much larger reduction in the rate of requiring like plasma coagulation or HBO for rectal bleeding, as well as cystitis and fistulas. Conversely, for those that have a really good response after external beam, guidance actually allows us to de-escalate from what the point A doses have been and hopefully also spare normal tissues.
Well, that's fantastic to hear, and definitely we'll develop a little bit more on that. As you know, we often have questions from our fellows in the journal. And staying on the topic of cervical cancer, this question is from Matteo Lovero in the Policlinico Gemelli in Rome. He's asking, in cervical cancer, chemotherapy has improved survival when given as induction before chemoradiotherapy, but not as adjuvant after chemoradiotherapy. So interlace in the outback. What do you think explains this gap? Tumor biology, earlier systemic control, debulking, reoxygenation, trial design factors, or the sequencing timing of chemotherapy relative to radiation? So we can do a whole podcast about that
I
question.
know.
Your thoughts?
This is really controversial. I wish I knew the exact answer, but I mean there's definitely some good hypotheses that have even been mentioned there. So induction therapy has been studied multiple times and it's been had mixed results really. And the way I see it is that the novel innovation from Interlace is the use of dose-dense therapy early in the patient's course. And that's certainly what the investigators identify as a difference between that and prior induction experiences. It's possible that this better addresses subclinical micrometastatic disease in a way to improve overall and disease-free survival. It may also improve local control due to the high response rate that's seen, both reducing tumor bulk and potentially reducing the central hypoxia, which is a known factor for radiation resistance. And both of these may make radiotherapy more effective. It's worth noting in this study that it was performed multiple sites globally, and that oftentimes, at least in the US, where we have high resources, that modern radiotherapy techniques that we just discussed weren't really used often on this trial. As such, I think anecdotally, the uptake in the US has been fairly limited. That said, we still lose about a quarter of our locally advanced patients due to eventual metastatic disease. I think any intervention that can improve this is very much worth further study. I know the NRG has just opened a trial of immunotherapy, plus or minus induction, GY037, which hopefully will actually go a long way to answer some of these questions and hopefully resolve some of this interplay between A18, which I think we'll discuss later, and Interlace.
Great. Carlota Sabini from Milan, staying on the topic of the interlace trial that you just discussed. She's asking, in the interlace trial, 59% of patients in the induction chemotherapy arm experienced greater or equal to 3 toxicities, compared with 48% in the standard chemoradiotherapy arm, which contributed to variability in radiotherapy quality. How can we best manage induction-related toxicities to ensure that radiotherapy and brachytherapy are delivered on time and at full dose without compromising outcomes?
Yeah, this is a great question. And one of the reasons why I think there's been some reluctance to use induction therapy, at least routinely here. As we know, timely completion of radiotherapy is critical for pelvic control. And anything that might compromise this is concerning. As this is a dose-dense therapy, I think close monitoring these patients, particularly a lot more than we would do with concurrent weekly cisplatin, is very indicated so that the entire treatment isn't compromised. It's also critical that they see a radiation oncologist pretty early in their course because the interlace protocol went straight into radiation therapy very quickly after completion.
Mm,
And this is an important part just to help reduce that delays and potentially compromising the eventual outcome.
yeah. There's still a lot of interest, obviously, in this concept of induction chemotherapy. Mateo Lovero goes back to it and asks, in these locally advanced patients, which patient factors, stage, primary tumor bulk, nodal status, the need for rapid treatment start, comorbidity profile, push you towards induction chemotherapy before chemoradiotherapy versus concurrent chemoradiotherapy with pembrolizumab?
Yeah, that's a great question, and really the key thing facing us right now. In our practice, we haven't routinely been integrating induction chemotherapy, and rather have been preferring immunotherapy. This is likely more due to our biases more than anything else. I mean, we do have the resources to start radiation therapy very quickly. Sometimes we can start within a few days if it's really indicated for a patient, but that's not true everywhere. Um, Again, one of the differences between interlace IMRT and image-guided brachytherapy was less commonly used than in A18, and that might make it more relevant to practice in a high-resource setting. We don't really have a formal treatment decision tool right now to identify who best to treat on either treatment paradigm. I know of other centers with more limited radiation therapy options might prefer induction therapy, particularly for large locally advanced tumors, as the response rate might actually make radiation therapy easier. That said, with modern image-guided brachytherapy, even again, locally advanced tumors, as we just mentioned with the EMBRACE trial, can often adequately be covered. At this time, we haven't again favored induction for most scenarios. We've at least talked about it for potentially, quote, radio resistant tumors such as HPV negative adenocarcinomas, but I don't really have any good data that it actually would outperform in that setting. And so we haven't really settled on on a uniform approach. It's really case by case, and again, we just discussed in tumor board and I think we've done just a handful of induction at this point, mostly Pembro at this point.
Okay, so then moving on from induction chemotherapy to, of course, obviously immunotherapy and radiation. We talked a little bit briefly about Keynote 818. This question comes from Saniru Marin in Mexico, and he's asking, immunoradiation is emerging as a key area of research. What lessons can you share? What have we learned from trials combining radiotherapy with immune checkpoint inhibitors in cervical cancer?
Yeah, so we were all very excited to see the A18 data with pembrolizumab. Although it's interesting to see that the benefit, at least on subgroup analysis, seemed largely limited to the more locally advanced stage 3 and 4 cancers by the older FICO staging systems, not counting nodes. Interestingly, this comes on the heels of the Kaya trial, which did not show an advantage with another PD-1 directed therapy. Why this is uncertain. They are different drugs, and potentially there's something deeper in this that we don't understand. So there are many preclinical models which would suggest that radiotherapy might prime the immune system with the development of in vivo antigens due to tumor death. However, there are also concerns that radiation therapy of pelvic nodes or other nodal basins might compromise the efficacy of immunotherapy due to its immune suppressive properties. Interestingly, A18 actually is the only trial combining radiotherapy and immunotherapy that I'm aware of that has shown a benefit when elective nodal basins were treated. We don't know why this is. Maybe there's something specific about cervical cancer and the exact agent used. Or it might be that the concurrent Pembro wasn't as effective as the Pembro after treatment. Either way, I think this is still a very exciting time, especially considering that the standard of care for cervical cancer hasn't really changed with systemic therapy for over 20 years. Again, hopefully the NRG trial that I just mentioned, looking at immunotherapy plus or minus induction, could give us some further insight into this.
Yeah. So this is a perfect segue for the next question from Paula Mateo from here at Houston Methodist about, about the patients with positive nodes. She's asking, given that Keynote 818, as you mentioned, showed a significant benefit, mainly in the FIGO 2014 stage 3 or 4A subgroup, how do you envision the role of immunotherapy in node-positive disease, and particularly in your own institution at Duke? Are you giving immunotherapy in the setting of node-positive disease?
Yeah, it's very interesting that this subgroup benefited more on the subgroup analysis. It's a little unusual for the FDA to approve an indication based only on a subgroup analysis. And usually we would use the inclusion criteria of a trial rather than those sub-analyses to define who might benefit from therapy. There is a risk of spurious conclusion based on that, but I think it's worth paying attention to. I think the NCCN, which I also participate in, has largely agreed with the FDA's impression on this and mostly, again, recommended pembrolizumab in more of the locally advanced patients rather than node positive. In practice, we do occasionally give pembro for node positive patients, again, just because we know that these patients have the highest risk for distant disease later on. However, I guess it's also worth considering that there are significant new toxicities with immunotherapy that are worth considering, some of which can actually be long-term and chronic even after cessation of therapy. So I think this gives us some pause using immunotherapy universally. However, ultimately, again, because the node positive patients we know have such a great risk of distant progression, it's really hard not to want to escalate therapy for these women.
Yeah. So to that point, this next question comes from Tommaso Meschini, University of Insubria in Italy, and he's interested in de-escalation, and he's asking, in the context of treatment, de-escalation for cervical cancer, do you envision that the introduction of immunotherapy may eventually allow us to reduce the amount of radiation delivered?
Yeah, I think this is another great question because as we get better clinical results with our therapy, we really need to turn our attention to reducing morbidity. And obviously, more targeted or reduced dose radiation could be a key part of that. You can actually think of image-guided brachytherapy, though, as dose de-escalation for those who have an excellent response, just because the doses that we're able to achieve are so much higher. We actually reduce our doses much more compared to historical point A based plans. However, we know we can't get away from brachytherapy right now. Non-brachytherapy related studies for SBRT have shown reduced control rates and higher toxicity, even compared to the older point A based plans. And in regards to reducing external beam, it does worry me about potential nodal recurrences. We're obviously such a huge risk with cervical cancer. There are studies looking at reduced margins and adaptive radiotherapy, which allow us to exclude more and more normal tissues from field. Adaptive radiotherapy actually involves imaging a patient every day and
Hmm.
redeveloping a new plan with exceedingly narrow margins and delivering it on the same day. We're looking to join one of that trial like that coming out of San Diego right now. Thus far, I don't think we get quite enough from immunotherapy to obviate or reduce radiation therapy. And I think it will require a sea change in systemic therapy to get there. But obviously, we're hopeful and we want to look for any opportunities to reduce morbidity in our patients.
Great. ACB Agra from Spain, she's asking a little bit about toxicity. Embrace 2 is a prospective study involving multiple interventions aimed to improve survival outcomes while minimizing toxicity to organs at risk in locally advanced cervical cancer. Can you provide us more detailed information about the specific interventions implemented in your institution to reduce adverse events?
Yeah. I think this is again getting right on the same wavelength as a prior question. So Embrace 2 is looking at both how we deliver external beam and brachytherapy. For external beam, it's looking at targeted nodal doses that dose sorry, targeted nodal dose escalation while try that again. For external beam, it's looking at targeted nodal dose escalation while maintaining strict control of normal tissues. It's also looking at a more stratified approach to brachytherapy. For those who have a great response, they might receive less dose, whereas larger tumors, they're going to try and dose escalate. I think the initial results have been presented at this point. I haven't seen a manuscript yet, but the results so far are very encouraging. Hopefully, both of these innovations on both sides of the radiation fence will drive both an improvement in clinical results and reduction in toxicities. And I think that's basically what the first report of this trial. I think it's almost 1,500 patients, and so we're really looking forward to the details. A lot of those innovations we've already kind of rolled into our practice here, but it's great because the protocol is published. I think you can look it up and see how it could work at your center.
Yeah. So now let's get into the series of questions on endometrial cancer. This next question is from Tommy Meschini again, and he's asking about sandwich approach to radiotherapy. And particularly, do you think that molecular profiling could play a role in guiding the optimal sequencing of chemotherapy and radiotherapy?
Yeah, I mean, and we kind of touched on this a little bit with the molecular classifications, which I actually think will probably help us more than anything else with figuring out who benefits most from pelvic control. What I don't know is how this influences our treatment sequencing, and really the distribution of disease and the potential residual disease after surgery has helped us define sequencing more than anything else. For those that with residual disease after surgery, we will sometimes prioritize radiotherapy due to the larger volume of residual disease potentially within the pelvis. For others, we've prioritized chemotherapy first, as distant metastasis will determine the patient's eventual outcome. We have really largely abandoned sandwich therapy, as at this point the rationale has become less and less clear. I worry about putting a break in the middle of chemotherapy might make it less effective and allow for growth and selection of resistant clonogens while taking the radiotherapy break. So really, our main decision point right now is for most people is to use chemotherapy up front, unless there is significant volume of disease left in the pelvis, in which case we might approach it with a more Portec 3 style chemoradiotherapy, followed by more chemotherapy afterwards.
Excellent. So this next question comes from Matilda Dell, and she wants to know about Portec 3 versus GOG 258. She's asking in Portec 3 for patients with NSMP endometrial cancer, chemoradiotherapy showed just a trend, not statistically significant, better 5-year relapse-free survival compared with radiotherapy alone. In GOG 258, in the P53 wild type NSMP-like group, chemoradiotherapy actually provided a clear survival advantage. Were there differences in the radiation fields, including any extension to the periodic region, the total dose, the use of vaginal brachytherapy? Could these variations have influenced the outcomes?
Yeah, so I haven't seen any really granular analysis of how radiotherapy different between these trials. From what I've seen in the manuscripts and the protocols, the radiotherapy appears to be fairly similar, although I would like any more details in that regards. From what I gather, it appears that the P53 wild type benefit both from chemotherapy and radiotherapy, um, as the risk in both distant and local regions are a little bit more balanced than, say, the P53 mutation, which in my mind explains these results probably more than anything else.
Excellent. Let's get on to a question by Paula Mateo. She's asking, considering the Rainbow Poly Mutant Blue trial relies on accurate poly identification to guide treatment de-escalation, and that poly testing is still unavailable in many settings, how do you see the role of poly testing in future clinical decision making? And I know you recently returned from a trip to Africa, and I think also obviously relevant to many other regions around the world for this question.
Yeah, I mean, we've discussing this, and it's a controversial area. For Poli in specific, again, in both these trials, they got some treatment in either on either trial, and so we don't know yet, at least for stage 3 disease, how best to do that. It's clear, though, that they probably don't need aggressive combined modality therapies. Um, Again, with regards to the other subtypes, P53 wild types, we have been using radiation therapy after chemotherapy, and the P53 abnormals, we've been using chemotherapy and then maybe doing vaginal brachytherapy afterwards. Again, it is going to be kind of an interesting new world that we're in, and I think ultimately we'll probably be treating uterine cancer as four different diseases. I think POLE will be addressed very different from the NSMPs or wild types, the P53 abnormal, and then also the DMMR. I think really, we'll need to, like, just like the Rainbow trial has kind of posited. I think we're probably our treatment algorithms are going to be very different. We're still waiting for all of the details on all of this to shake out. But I suspect in 5, 10 years, these algorithms will be much more solid and more based on really prospective trials.
Great. So now, Junzo, a couple of questions on, of course, obviously, vulvar cancer, which we haven't covered. These two questions come from Masha Pervin in the hospital, University Hospital in Munster, Germany. The first question is, in vulvar cancer, with positive inguinal node, would you recommend radiotherapy to the groin and the vulva in the context of the subset analysis of the AGO Care 1 study that, although retrospectively demonstrated a better local control after radiation to the vulva as well as to the groins for patients with positive nodes, would you decide differently for micrometastases versus macrometastases?
Yeah, exactly when to treat the vulva when we're already targeting nodes is an area of controversy in the radiation oncology community. Unfortunately, the data we have is largely in these kinds of retrospective analyses, which are obviously subject to some selection bias. The first data I'm aware of this actually dates fairly back in years now, back to Dusenberry, who found that vulvar recurrences were high if the vulva was blocked during nodal irradiation. But the AGCO Care 1 trial is much larger. That said, we tend to include nodal involvement as a risk factor along with margin status and other factors for local recurrence at the primary site. If the pathologic findings are extremely favorable, we sometimes will still omit vulvar treatment just because it's the area where most of the toxicity associated with radiation therapy is present. It's always a consideration, though. We always have it on the table, and usually we'll discuss it with the patient. I don't know the degree in which nodal involvement, micro versus macro metastases, will affect this. Certainly micromets have better results with radiation alone. Macromets, in the groin at least, need some kind of treatment intensification in regards to the groin, either completion dissection or a higher dose with chemotherapy based on the groin's V2 data, and now the subject of the groin's V3 study. But how this directly affects vulvar risks is a little bit still unknown, and we tend to consider this on a case-by-case basis. But I always consider treating the vulva if we're already treating the nodal basins, and it's just a matter of really trying to carefully balance those risks.
Excellent. Her next question is about HPV status. And she's asking, do you consider HPV status in your radiotherapy recommendation for vulvar cancer? Do you think we have enough evidence yet to consider it a predictive factor for response to radiotherapy, or is it a factor of tumor biology in general?
Yeah, I think probably both. I think it's clear now that HPV status is both generally prognostic, as far as predicting a better overall outcome regardless, and predictive of radiation therapy responses as well. And I think this is a fundamental factor in the tumor biology. Again, like we talked about with uterine cancers, I think these are going to be treated like two different cancers moving forward. Although as of yet, it doesn't really change our treatment recommendations. If I'm treating an HPV positive patient, I'm certainly more optimistic about response to radiation therapy. They're much more likely to have much less likely to have recurrence or residual disease if we're treating them with primary radiation or chemoradiation. But conversely, if we're talking about the HPV negative patients, we're really limited by tissue tolerance and can't dose escalate beyond a certain point. And it's really difficult to get beyond 65 to 70 gray, which might actually be necessary to improve local control for these patients. Potentially brachytherapy for gross residual disease after the initial phase might be a consideration, particularly for these HPV negative patients. Although I don't often do this, the risk of skin and vulvar necrosis is very significant. And probably what we do more frequently, these patients, we still do chemoradiation for the HPV negative patients with intact disease. But we watch them very carefully, and really we sort of reserve surgery in that setting, early surgery if possible to remove, I mean, early meaning, after a full allowance for response, like 3 months or so. But, pending new findings, we optimize our treatments as much as we can. And unfortunately, we don't make different recommendations right now just because of the limitations of what we're able to do.
Yeah. This next question comes from Mo Byrne at the Memorial Sloan Kettering Cancer Center in New York. Question that often asked by many patients: proton beam therapy. And she's asking, proton beam therapy demonstrates dosimetric promise for the treatment of gynecologic cancers, primarily in the domains of reducing morbidity of treatment, potentially allowing for safer escalation of radiation dose and re-irradiation. Early data suggests safety and efficacy, though we are lacking a larger prospective trial to confirm this and assess oncologic outcomes on a larger scale. So she's asking, can you comment on the potential role of proton beam therapy in our field?
Yeah, I think proton therapy is another exciting development. It does offer significant advantages for normal tissue sparing. For those who aren't radiation oncologists listening, this is because proton therapy has no exit dose, unlike photons, which just goes through and through. Proton therapies sort of deliver their payload, so to speak, and then go no further. In practice, however, the clinical benefits are really more iterative than transformative. And while there hasn't been a randomized control trial in GYN patients at this point, it's been fairly hard to show a difference in clinical outcomes in a lot of other diseases. For pediatric patients, I think that's one of the clear advantages for proton therapy, just because the dose spill out is much less, and obviously they have much higher risk for, secondary malignancies and things like that. But for most adults, and particularly GYN patients, its best use has been yet to be determined. I've seen some trials looking at nodal RT in GYN indications and single arm sort of studies. And again, there are dosimetric benefits looking at the plans, but the significant clinical benefits, I just haven't yet seen them be established. This is also taken in context that there's significant access issues in regards to cost and availability. These are really expensive. So for right now, I think its best use seems to be for more difficult reirradiation cases. But I do think the G1 radon community is really interested in further investigation here. In regards to will it ever replace brachytherapy? Again, I don't think anytime soon. The same limitations we see with photons will apply for proton therapy. That said, at Duke, we currently don't have protons available. That'll change actually in about 4 years now. But I do think there are probably cases where it would be useful, particularly when conventional options are either limited or exhausted.
Excellent. So, Jensen, one last question from our fellow Zaniru in Mexico. He's asking, as we hear about all of this technological innovation in gynecologic radiation oncology, and we see all these advances, how can we ensure that progress also remains inclusive of our countries to strengthen the global practice standards?
This is so important, particularly for cervical cancer. The innovations we've been discussing really require a setting with adequate resources, and these are simply not available where most of our cervical cancer cases happen. There are countries where RT is just not even available, let alone brachytherapy. In those who do have access to radiation therapy, MRI imaging is a lot more difficult to obtain and sometimes has to be paid for by the patients themselves. The IGCS has actually made this a priority in the last few years and has been implementing a international gynecological radiation oncology consortium.
Mm.
Again, you can't do any work without making an acronym of IGRO in this case. Utilizing some of the success of the Gynonc Fellow programs to engage the radiation practitioners in a paired mentorship and training program. I've had the pleasure to be part of this. The sites, initial sites in Uganda, Vietnam, and Ethiopia, which I just went to, have been the first to enroll in this year-long pairing of centers who are at some point of transition in their care, either 2D to 3D external beam or IMRT, or from film-based brachytherapy to more image-guided treatments. There is a growing literature aimed at transferring the benefits and insights from things like the Embrace study to regions that are more resource limited. There's a paper from the Indian Brachytherapy Society, ASTRO, and ABS, American Brachytherapy Society, about best practices for CT-based brachytherapy, which can benefit many more patients with cervical cancer than have access to regular MRIs. This includes the use of CT anatomy and ultrasound to improve care over film alone. And those sites without adequate access to radiation treatment, we can advocate for minimum treatment standards to ministries of health to justify investment into a radiation infrastructure. The IAEA has been putting together packages of low-cost radiation equipment to countries of varying levels of resource. And simply put, we just can't allow women to continue to we simply put, we can't allow women to continue to die of this disease just because of where they're born. I think we can all play a role in advocating for adequate therapies and improvement of care across the globe.
Yeah. So, Junzo, as a tradition now in our podcast, the last question comes from AI, and actually, it's a perfect segue from your last answer. And AI is asking, does the current enthusiasm for checkpoint inhibitors risk eclipsing the real fundamental improvements that are needed in radiation delivery quality, particularly in resource-limited regions?
That actually is a really interesting question and really does follow along with the prior question. And while immunotherapy provides a real benefit for patients with GYN cancers, its benefit in non-DMR patients, at least, is moderate and reliant upon high-quality radiation therapy to be effective. There's also no small cost involved to begin treatment with checkpoint inhibitors. And there is a danger of misprioritization of resources. Incidentally, you could say the same thing about proton therapy. Ultimately, it's really up to all of us to more clearly communicate the large benefits of first access to radiation and then improving radiation quality and infrastructure when there is access. Again, the WHO, IGCS, IAEA, SGO have all taken significant measures to codify what the standard for cervical cancer practice should be. And I think we should all take the opportunity to elevate these voices globally.
Great. Well, Junzo, thank you so much. It's been such a pleasure. Learned a great deal from this conversation. Thank you for your publication of this article. I think it's going to be a reference article for many of us who are obviously seeing patients with gynecologic malignancies. Thank you again, of course, obviously, for your contribution to the field of radiation oncology and gynecologic cancers. Really a pleasure.
Well, thanks, Pedro. It was definitely my pleasure to participate in this discussion. It's an exciting time.